For a Pes Planus deformity, uh, the patient can be seen with a lateral side heel pain with calcaneal impingement against the fibula. On Pes Planus, as deformity describes, this is when the medial arch is lost. On first examination, I will examine the patient's shoes and check out for the wear on the medial side. I will also check for the gait. The patient can have reduced plantar flexion because of tibialis posterior dysfunctions. Hind foot would be in valgus and forefoot abduction might be present with a too many toes test positive. A double heel raise test is done to assess for the subtalar joint, while a single heel raise test is done for a tibial posterior tendon insufficiency and should be repeated 5 times. Tibialis posterior, when it's insufficient, we need to check its power, which is by the inversion and plantar flexion. Moreover, a gastrocnemius assessment should be done. So in an adult, the most common cause is posterior tibial tendon insufficiency, while in pediatric population it's mostly because of tarsal coalition. Regarding generally the causes can be divided into congenital, acquired, and physiological. Congenital is like vertical talus, tarsal coalition, spina bifida, and cerebral palsy. Acquired will be posterior tibial tendon insufficiency caused by rheumatoid arthritis, polio, or degenerative. Physiological means that there is a laxity. Normally it is present in 40% of children less than 10 years of age, and it is about the incidence 10% in 10 years age. Regarding the physiology, when the tibialis posterior is lost, it's mainly an inverter. It is parallel antagonist to peroneus brevis. So peroneus brevis is acting, which cause eversion of the foot. Moreover, when it is everted, the pull of the gastrocnemius or the Achilles tendon is lateral, which created more hindfoot valgus, and there is prospective progressive tightness of the triceps surae muscle, causing even more valgus deformity, and the end there is deltoid insufficiency. In any Pes Planus deformity, I need to take a history, which I described above. Then I will do some simple images, which consist of weight-bearing AP and lateral view. In AP in PA view, I will need to check the talocalcaneal angle, which will be more than 35, and this is because of divergence due to heel valgus. Moreover, I can check, this is called talocalcaneal angle, which is kite angle. Then I will check for the talus first metatarsal angle, which will have a loss of collinearity, and the Miri angle will reduce to less than 4 degrees. In a lateral view, I need to check the calcaneal pitch will be reduced, and I need to do oblique views to rule out tarsal coalition. Regarding a decision for the surgery in Pes Planus deformity, it depends on the patient. In patient general condition, I want to check for the Beighton score of the patient. Also, my clinical examination findings, that is either single heel raise is possible or not possible. And third is the stage of the Johnson and Storms. So if a patient has mild symptoms of posterior tibial tendinopathy, I will do a arch support, heel wedges. I can put a cast as well, or AFO, and refer the patient for physiotherapy with a controlled follow-up. If the deformity is flexible, I can advise orthotics with the longitudinal arch support. In the patients who are not responding and the pain is severe enough and and there is a flat foot deformity and the patient is not able to do a single heel raise test, I need to further investigate such patients with the MRI to identify the tendinopathy. If I can identify the tendinopathy, I will possibly some of the patients will improve with the debridement itself. In those cases where the posterior tibial tendon is degenerated, I can decide for a flexor digitorum longus transfer, which should be done, which is synergistic and is a stronger muscle when compared to FHL. Moreover, important is to check for the heel cord tightness and add Achilles tendon lengthening for those patients. If there is no bony deformity and there is still there is a subtalar involvement, I can do arthroeresis, which is basically a sinus dorsi implant which is applied laterally and avoids the heel valgus. In those patients where the deformity is now bony and I can see that there is a spring ligament disruption, I can do a tibialis posterior reconstruction as well as adding a spring ligament repair. Furthermore, nowadays a bony procedure like lateral column lengthening like Evans procedure or a medial wedge osteotomy of the cuneiform like Cotton procedures are added in stage 2B. In more arthritic patients, I will go on for a triple arthrodesis along with tendo-Achilles lengthening and deltoid ligament reconstruction. And even if more severe deformity like ankle arthritis, I can go on for fusion.